Thank you, folks. I never quite know what to make metaphorically of when palliative care is at the end of the conference. But it's certainly something I'm not unfamiliar with. We've dealt with this. And we're really going to focus on a lot more in the pre-end-of-life phase, really upstream management of quality of life and symptom management. And the slides that you have are almost complete. There were 2 up-to-date slides from the CDC that I wanted to get that I didn't have access to. So they're blank, but I'll be happy to send you the final ones. You'll see they're at the end, just kind of blank. So again, when I talk about palliative care, we're really not just talking about the top or the end-of-life concerns. We're really talking about how do we manage symptoms that are difficult or even intractable, but really how do we preserve dignity and quality of life? So what we just heard about in terms of sexual pleasure is very, very important, and certainly that's a quality of life factor. And I can tell you that just as patients with ovarian and other serious pelvic surgeries, there are lots of people who have left ventricular assist devices where their left ventricle is being offloaded and they have a drive line coming out of their abdomen, and that makes sex very difficult for them. But they figure out how to do it. So these are very, very important factors regardless of if someone is seriously ill. So what defines quality of life and what defines dignity for folks can be very, very broad depending on what their preferences are. So to kind of couch this talk about pain and really focusing on pain, I want to at least focus on the NCCN guidelines, which most of you would be familiar with. And again, the most recent versions from 2017. But what I always find interesting about the NCCN guidelines is they are just guidelines. In terms of their evidence base, they're really category 2A recommendations. So we're looking for some sort of recommendation or consensus, and there's lots of ideas here. But particularly when it comes to palliative care, when we're taking care of seriously ill patients, the degree to which we can rely on clinical trials to kind of guide us is more challenging. And I think not only are we challenged by not having evidence in terms of clinical trials to guide us of what the optimal treatment might be for cancer-related pain, but we're also dealing with a very, very, very stringent, very out there crusade against opioids and against illicit opioid use and against opioid misuse, and all the challenges that are being put forth by the CDC and the state of Alabama and the DEA, et cetera. All of which are very, very appropriate because there is a problem. But what we're going to talk about today is there's often a problem where we have patients with serious life-limiting or life-threatening illnesses that have problems that aren't being managed. And when we have patients who are particularly have limited life expectancy, it's morally wrong to not treat them with appropriate analgesia. It's morally wrong to not treat them to make sure that they have appropriate symptom management. It's challenging, but I think we all could work together on those challenges, and that's what hopefully we'll talk about some opioids, but we'll talk about ideas other than opioids as well. So if any of you have ever looked at the NCCN guidelines for whatever, it comes down to a bunch of little print that you really have to kind of squint and look at and figure out which line you want to look at. And for the first slide with the NCCN guidelines for cancer-related pain, it really comes down to, well, is the pain mild, moderate, or severe? And that mild, moderate to severe is something that, again, has been used time and time again with our World Health Organization pain ladder. Well, gosh, if someone has mild pain, we should only use things like acetaminophen. If persons have moderate pain, maybe we should use a weak opioid. If a patient has severe pain, maybe then we'll use opioids in that particular situation. So this is something that's very universal and familiar with any type of clinician. But I think the ones that are most important, particularly for our patients with cancer-associated pain, is the top level, where we need to consider how do we manage concurrent symptoms that might occur, nausea and constipation. How are we providing concurrent psychological or social support, given what this pain means to them in the course of their cancer? What does it mean to them in the terms of their finitude and their potential risk of shortened survival? What types of integrative therapies are available? And what types of meds can we use that work together to potentially help more than one problem? So these top issues become much more important for those that are dealing with cancer, and we're going to talk in specific about that. So when I think about managing patients that have cancer pain, and I do adult medicine, I'm really looking at a history and physical as being something that's super important. I want to know if they say my back hurts, that doesn't really help me because their low back hurting, midline versus paraspinal, their back being really a thoracic pain that comes all the way around underneath the rib and stops in the midline is they're all treated very, very differently. So really understanding what might be causing the pain and understanding their opioid or drug history. And it's not just a matter of, oh, someone gave me oxycodone 5 milligram tablets and they're not working very well. I'm very honest with my patients and okay, that's fine. I need to know, tell me about, have you ever used drugs in the past? And I'm not asking you because I'm suspicious. I'm asking you because if you did heroin every day in the 70s, 5 milligrams of oxycodone is essentially like some of that delicious sugar sand that's out on the beach out there. It's going to do nothing because people's bodies don't forget tolerance. They might forget tolerance, and that's why we have problems for a short period of time where they used a big syringe of heroin and they go back to it and overdose and die. But that doesn't mean that for our patients that we're dealing with using licit medications, licit opioids, that really we need to consider that 5 milligrams of oxycodone or 2 milligrams of IV morphine might not be enough, particularly if that person had low back pain for 25 years and was on long-acting oxycodone or a fentanyl patch or goes to a methadone clinic. So we need to be aware of all these things. When we think about the tumor, it really comes down to, is the tumor itself causing problems? Is the treatment itself causing problems? And what is it causing problems for? Is it causing problems for our bone? Is it causing problems for our viscera? Is it causing problems for our nerve? Or when we think about gynecologic cancers, a little bit of all of those, because we have a whole lot of nerves and a whole lot of tissue and a whole lot of bone that can be affected in the pelvis, either by the tumor or by the chemo, the platinum-based chemo that we're giving, or by the radiation that really doesn't care what it is, it's just going to kill it. So we really have to be very, very thoughtful about where is this pain coming from so we could pick the right medications to treat it. And I still have to say that for cancer-associated pain, particularly for patients that have a limited life expectancy, that opioids are going to remain the mainstay of therapy. The real responsibility that we all bear is that we have to do that responsibly now. We have to think about how are we justifying this? How are we keeping it safe? Because I think we all remember, I could think back when I got my wisdom teeth out, maybe, I'm not even going to say how many years ago it was. It's a lot more than I'd like to think it is. But you just got a prescription for Norco for 20 of them, 30 of them, for a 14-year-old getting his wisdom teeth out, right? Because in America, it's all about not having any pain, right? You're either in pain, and if you're in pain, that's a negative, that's a ding. So then we get all the way to the other side where we're like, no, we can't do that anymore. We really have to ration and let people just kind of grit and bear it. And that's probably not the right approach either. We have patients that have serious pain. We have to responsibly think about use of opioids in these patients. But opioids aren't the only things that could be helpful, fortunately. If we have patients who have either visceral irritation, if we have osseous destruction by a tumor, corticosteroids, great medication. Short term, can really help with a lot of the swelling. We talk about non-steroidals later, but I've never boxed anybody's kidneys with steroids. That might have made their sugar go up a little bit. Maybe they needed a little more insulin, or maybe we need to make sure that they have some gastric protection. But in terms of steroids versus non-steroidals, often in my world, I'll end up using the steroidal just because we may get a little boost in energy, we may get a little boost in appetite, we may get a little boost in just overall sense of well-being, as well as relief of bony pain or visceral pain or capsular stretch pain. Bisphosphonates, there's certainly reviews that suggest that bisphosphonates can be helpful adjuvants in terms of helping with bony metastasis. But again, it's not a first-line agent. But I think if someone comes to me, and even if they don't have hypercalcemia, but they have osseous metastasis in the spine and the pelvis and the long bones, and they're on opioids, and they're on maybe even some corticosteroids, if they haven't had a bisphosphonate yet, I'm going to make sure that unless there's a very strong indication that they should get it. Now, I live in Alabama. We all live in this area. We all know that there's great socioeconomic differences between the patients that we care for. So where I might have practiced previously, where everybody got bisphosphonates very quickly, you really have to think about bisphosphonates and their risk. And the risk is all about the jaw. And when we have people who come in with bad teeth, or teeth that might need to get them pulled at some point, or abscesses already, these are things that we need to consider. So I don't say that everyone should get bisphosphonates, but I do absolutely ask them, how are your teeth? If they look normal, I still ask them, but sometimes you could tell right off the teeth are going to be a problem, and if they're going to have those teeth pulled or other problems, or if they're going to be long-term survivors, we really, really need to think about if this is something that we're going to do. I think acetaminophen, I like just using it by itself rather than in combination, and we'll talk about that a little bit later, because I think when we use it in combination, we get into trouble. And NSAIDs, I think, again, are useful for our younger patients with good kidney function, but we really need to think about the side effects for some of our older folks. So we're going to talk about a 70-year-old patient with endometrial cancer with bony metastasis admitted with an L1 compression fracture. There's no cord compression. She's short of breath because she also has COPD. Remember, the patients that we take care of rarely have just one problem anymore. Usually they have 5 or 6 or 14 things going on to address in a 15-minute visit. But you're worried about this pain. You know it's legit. You know that she's got some borderline renal function. She's getting her weekly paclitaxel and tolerating that, and you're very carefully watching that renal function, making sure it's not getting worse. She's on medications for some heart failure, some CAD, some depression, and oxycodone previously made her goofy. So in this situation, no hands, no buttons, no anything, can't see you. Just going to ask the question though, what are we going to do? Are we going to start some low-dose oxy, maybe scheduled and PRN? Are we going to start some tramadol? Are we going to start some hydromorphone orally? Are we going to start some morphine liquid? Or are we going to do some ibuprofen and acetaminophen alternating? Which, if you have young children who are febrile, that works really, really well. Every kid knows. My 13-year-old had 104 fever, and it's like, yep, you get number 5, and it works great. Unfortunately, it doesn't work great for people who have heart failure and borderline renal function. Probably not a good choice. Our morphine's probably not a good choice with renal function. We'll talk about tramadol specifically and why it causes extreme nausea for me, not for the patients, because it's not a very safe drug, even though we like to lull ourselves to sleep to thinking that it's a safer drug. And if oxy really might have caused some delirium, I think we'd go with some oral hydromorphone, again in low dose. So that person, you saw them, you wrote some orders, they came over to the emergency room, and now they got admitted. The doc downstairs said, we're going to go ahead and give them some morphine, and they tolerated it okay. Again, it's not an absolute contraindication. We just have to be careful with our morphine for patients with borderline renal function. She got 4 milligrams, she got 4 milligrams, she got 4 milligrams, and it's helped. And now she's, it's helped, actually, I should say, 4 milligrams, 30 minutes with no benefit in the ER. So now she's up to you. So hasn't really helped as much as you would expect. So last dose was 30 minutes ago. You have this patient like this. Well, what are we going to do? Are we going to give another dose of 4? Are we going to wait 30 minutes because you have to wait an hour in between doses? Are we going to maybe go up to 8? Are we going to start a drip? Or are we going to do ketorolac? And I think, again, the ketorolac is a great drug. If I come in with a kidney stone, by all means, something about Alabama has brought them about in me, so I have a new respect for renal colic. But I also respect that Toradol is a great drug, ketorolac. But I think here, if we have to realize if something's not working, we have to double it. And those questions really set up what I'm thinking about in terms of opioid utilization. For someone who is opioid naive, we think about a 5 to 15 milligram dose of morphine. It makes sense. That's why oxycodone and hydrocodone tablets are about 5 milligrams. That's a reasonable starting dose. And then when we think about the IV, we have to remember that the IVs have different equianalgesia, and we'll talk about that very briefly, an easy way to remember that. But those are good starting points, and you could start an equianalgesic dose of oxycodone orally or hydromorphone orally or parenterally if needed. We try again to avoid the acetaminophen containing, because everybody that I have that has hepatocellular cancer or who has something metastatic to their liver ends up on at least 8 tablets of hydrocodone/acetaminophen per day, and then they say their pain's not well controlled and they don't want to switch to anything else because that hydrocodone really works well for them, but they're already at that 2650 of acetaminophen that I really don't want to go past. So that's why, if we can, I'd rather just start someone on a plain oxycodone or plain hydromorphone or plain morphine and know that I could choose to add the acetaminophen if I want, but I could up-titrate that medication if I needed to. If the person's tolerant, if they've been on drugs, if they have other issues, we need to know what they're using. And we're going to talk about that a little bit because there's lots of different ways of looking at equal analgesia. The way I describe it to most people is, all we're really thinking about is that all these different drugs are different currencies. So for us to really understand, you could have francs and Deutschmarks and pounds, or everything's just euros. You need to know what is worth what. You need to know the exchange rate. And the exchange rate is basically our equal analgesic table. The way I look at it is, these are hard to memorize. So everybody tends to have to know that morphine 3 milligrams orally is 1 milligram IV. That's kind of the basic med school kind of thing that we had to learn. So if IV morphine is 1 and oral morphine is 3, there has to be a 2 in the middle. And the 2 in the middle is the next most common drug we use. It's oxycodone. So that's 1, 2, 3. 1 of IV morphine is 2 of oral oxy is 3 of oral morphine. And since it's a ratio, it could be 1, 2, 3, or you could add zeros to it. It could be a ratio of 10, 20, 30. But if I end up doing that 30, 20, 10, we could add 7.5 and 1.5 to that ratio, and that's where we get our hydromorphone oral and our hydromorphone IV. So for me, I try not to think about it's 2 to 1 or 10 to 1. I try to think about, this is what I have, and I go back to chemistry 101 in college and think, what do we want? Just like we could take how many grams of sodium and figure out how many moles are in it by multiplying it by grams over 6.02 times 10 to the 23rd, which gave some of you palpitations even just saying that number. It's much, much easier to think about, gosh, if I have 30 of oral morphine and now I go over, 30 of oral morphine goes on the bottom and then whatever I want on the top, and then the units cancel out. So I don't try to remember it's 5 to 1 or 4 to 1 or this. I try to remember the ratio so that we can do that. And if somebody is on opioids, we want to know everything they're on. We want to add it on up. And then once we add it on up, if they're really in pain, we want to do 10 to 20% of the daily dose. So if they're on 60 milligrams of long-acting morphine and 15 milligrams of short-acting morphine, they got 3 doses of each. That's 60, 60, and 60 is 180. Plus 45 is 225. If they needed a dose, we would want to pick somewhere between 10 and 20% of that 225 of oral morphine. Now, these numbers go by very, very quickly when they're just being spewed, but what I want to point out is that we just had a very nice review paper in Annals of Internal Medicine on palliative care, which was published the first week of March. So it's Swetz and Kamal in Annals of Internal Medicine. And there's examples and there's tables and it walks you through all this, so don't feel like this is something that we need to spend a whole lot of time on, but sometimes doing it on paper is helpful. Okay, so sometimes we have patients like this. They got the morphine, the right dose, and now they're not going to go to surgery. They had a portacath that was put in, but now it's not working, and the person says, gosh, I have so many veins that are scarred from this chemo. They'll never be able to draw blood. That's why I have a port, and now it's not working, and I'm in pain. What do we do? Well, the person's NPO, but that doesn't apply. She's not going to surgery. So should we give some high-dose oral medications? Should we give something IM? Should we give something sub-Q? Should we do a patch? Should we do a PICC line? Because, gosh, those PICC nurses can find just about anything. Or maybe get some alteplase, or maybe we'll put an IJ in. Lots of different choices. I've heard all of these throughout time. And the truth is that what we often forget about is that that opioids are very well absorbed subcutaneously. So when you have somebody who's in the office, when you have somebody who's there and they lost their IV, please don't give them an IM injection because it's very erratically absorbed and doesn't disperse very well into the muscle, particularly patients that have cancer that might have sarcopenia, etc. And I've asked nurses sometimes, I said, can you please go ahead and give sub-Q morphine to this patient? And they say, well, I've never done sub-Q morphine. How do I do it? I say, it's kind of the same way as sub-Q insulin or sub-Q low molecular weight heparin. You find a little skin and you pop it in. So I think this is one of the things when we see patients that are in pain, particularly in the acute setting, and we're like, oh, they don't have an IV yet, what are we gonna do? Something very, very easy that we need to remember, because if you take a pill, it takes about an hour for that pill to peak. That would be an immediate release pill. So whether that's MSIR or OxyIR or hydromorphone or hydrocodone and acetaminophen. If you do something IV, it's probably about 6 minutes for fentanyl, probably 10 to 15 minutes for something like hydromorphone or morphine. But really, if we're doing something sub-Q, it's about 20 to 30 minutes, so it's much quicker than the oral. It's not as good as IV, but when someone's in really severe pain and has a legit reason to do this, it's something that absolutely can be done. And this is where you see things like kids in the emergency room. The pediatricians have figured this out, where a little sub-Q opioid and a little intranasal ketamine, and they're out in some la-la land while they're getting their broken arm kind of fixed back. And I think sometimes that when we have patients acutely in pain, particularly if it's due to something very serious, we kind of forget about that. In terms of long-acting opioids, I think that the main things we'll talk about is we don't want the long-acting opioids to be our first choice. We have to recognize when we start them, they're going to take some time to work. So particularly things like our transdermal fentanyl patches might take about 12 to 18 hours till they kick in. So we need to make sure they're still getting their long-acting opioid, their multiple short-acting opioids until that long-acting kicks in. Side effects. I think we all deal with side effects. When we think about sedation, that's certainly one of the more common ones. I get sleepy when I take this. I don't want to be sleepy. I don't want mom to take that medicine because she gets drowsy when she takes it. And she needs to be alive so that she could fight and she could eat and she could do all these things. The things that we hear families say time and time and time again. What I usually focus on is, listen, this will get better over time. After she takes a few doses, her body will get used to it. If it doesn't, we could always cut the dose down. If it doesn't, we could always switch to a different pain medicine. If it doesn't, we could always say maybe oral's not the right route. Maybe we need to get her caught up with some IV. Or if she gets really nauseous with the IV, maybe we just need to try the oral instead. Or maybe we need to try a stimulant for a period of time. But I really struggle with families who are like, I don't want to give my loved one this medicine because of something that benefits them when we need to benefit the patient. Which means if the patient's going to be able to tolerate chemotherapy, if they're going to be able to be up and at them, they really need to have good pain control, because sometimes we underestimate that. We blame the medicine for the problem when really it's lack of pain control that's keeping the person from being active as they should be. Nausea will occur within 60% of patients who have opioids, whether it's oral or whether it's IV. It usually gets better over time once the levels kind of level out. So they might need a little bit of prochlorprazine or metoclopramide or some other kind of antiemetic for the first day or two. But again, saying I'm not going to take the pain medicine because I'm worried about being nausea, uncontrolled pain in and of itself could be a big source of nausea for patients. So we need to recognize that. Constipation, I'm sure in the practice, particularly when we think of our gynecologic cancers, we could have a whole host of issues with bowels, from too loose to too bound up. But we need to remember that opioids, when people use opioids, they will generally become constipated, and that while nausea and sedation get better over time, the constipation doesn't get better over time. It's important to think about using things like stimulants, so either Senecot or Bisacodyl. The use of Docustate alone probably doesn't do anything. Particularly if you're giving people pain medicines at the same time, Docustate just doesn't work. But I see a lot of people who take 20 pills a day and then don't want to eat, and 3 or 4 of those are Docustate tablets or capsules, which I'm like, you really don't need those little red jelly things. Oh, that's my laxative. No, it's really not. It's a stool softener. And for it to be a good stool softener, we need to not be affecting its motility by using opioids, which are really slowing gut motility down. So you can make soft poop, it's just not going to go anywhere. We need to get the poop going somewhere. And that's using stimulants, or that's using osmotic agents, like polyethylene glycol, sorbitol, or lactulose, where they just absorb so much water in there that it just pushes things forward, even if the gut really isn't squeezing it along like it should, because the opioids slow that down. And lastly, delirium or confusion. Yes, dad could have got goofy from that first dose, but really, again, it doesn't mean that they can never have opioids. It means that maybe they need a different dose, maybe they need a different drug, maybe they need a little bit of haloperidol, a dose or two, till they could get their pain under control and begin to tolerate this. Or maybe we just need to pick a different route or drug again. Could be very, very helpful. And again, untreated pain is a good reason to be delirious in and of itself. So I think you're kind of getting my theme of untreated pain can be just as bad sometimes as well-treated pain, the side effects of medicine in patients who have serious illness. When we think about the drugs to pick, we talked earlier about morphine, and morphine 6-glucuronide, one of the breakdown products, needs to be cleared renally, and that's an active metabolite, so people can have prolonged effect of morphine if their kidneys aren't working. They also accumulate the morphine 3-glucuronide moiety, and that one isn't specifically active as a analgesic, but it is active as a neurotoxic molecule. So people will get myoclonic jerking, they will get potentially seizures. It can be pretty downright miserable for folks. So we try to catch that early, and if you see your patient on morphine and their kind of arms are twitching, really, really, really important to say, okay, we need to get you off that morphine. And you don't have to have severe renal dysfunction to get that. It's rare, but when you see it, it's pretty unpleasant to have to deal with. A lot of people will say, I'm allergic to morphine. Why? Well, it causes me to itch. Well, morphine causes mast cells to degranulate, so it causes everyone to itch a little bit. That's not a true allergy. And the rate of true IgE-mediated anaphylaxis with morphine is actually quite low, but a lot of people will itch with it. A lot of people will itch with most opioids, and again, that's a mast cell phenomenon. It tends to get better over time, just like the nausea and sedation over time tend to get better too. We think about hydromorphone, and it may be preferable for our patients who are elderly or have renal failure because there are no opioid metabolite, no active metabolites. It's kind of a misnomer. There are opioid metabolites that are there. They just have extremely low affinity for the opioid receptors. So it's really something that's not going to cause us to get into problems. However, it's important to know that when people do take a whole bunch of hydromorphone for a period of time, you will start seeing their drug screen turn positive for morphine, and sometimes they're like, well, where are you getting that? And it's through an alternate pathway that, again, there's no low affinities, but there's a small amount that could actually get converted to morphine through complex organic methods that no one wants to know about at the beach on a Sunday. In terms of fentanyl, suboptimal choice for patients, and again, I say not the choice, but if someone has cachexia, you need fat, you need the drug to go from the gel through the skin into the fat and from the fat into the bloodstream. If they don't have a lot of fat, that affects that. It doesn't mean that it doesn't work, it's just very erratic and unpredictable. So if someone has 100 micrograms of transdermal fentanyl on and they're very, very cachectic, and now we're worried about switching them over to something different, I can't trust that their body is seeing all 100 micrograms of that fentanyl patch. I might very aggressively reduce and say, based on how thin they are, they might be getting a third of that. So I'm going to be really careful when I pick something IV to give them, and not just say, oh, they're on a 100 microgram patch, let's put them on an equal drip of morphine, because they'll just go to sleep right away. Dehydration, again, when we have dehydration and when we have fever, we tend to have things like vasodilation and vasocontraction. So dehydration, blood gets shunted away, our skin tents. Well, if our skin is tenting, then how the drug gets absorbed and taken from the fat into the blood changes. Or if we have fever, certainly our blood vessels can dilate and we could get more drug into the system. So the person who has a stable 25 microgram patch on, but now comes in with urosepsis and a fever of 102 and they're confused, yeah, we need to get that patch off them because they might be holding extra levels of drug that their body's just not used to. Very short half-life for the IV. So again, the worst thing that I see from house staff is that they'll write 25 micrograms of fentanyl Q6 hours, which is just like a cruel and insane joke because the drug is probably peaking at 6 minutes and gone by 15 minutes. So then you've sentenced them for 5 hours and 45 minutes of no analgesia. So really, if we're writing for fentanyl, if I'm writing for it as a PRN drug, as a boost, usually the highest amount that I'll put it is Q1 hour, maybe Q2 hours for somebody that's really old and has poor metabolism or other issues. But that's usually, for a PCA, this isn't going to be one that you're going to just give them every 30 minutes. They're going to need something a little bit more frequently than that. So every time I give a talk, I put the Jimmy Fallon slide in for my daughter Rachel, who thought that Jimmy Fallon's ride at Universal Studios was by far the greatest thing of any trip that she ever came on. She was very happy on the beach here playing in the sand yesterday, so I might have to put a picture of Perdido Beach Resort next to Jimmy Fallon next time. But there are some drugs that I think we still hear around and they just make me cringe. Codeine certainly is one of them because codeine is a completely inactive drug unless your liver can activate it. So I always say codeine is a great drug for me if I have a cough, but it's never good for a patient who has cancer-associated pain. It's not even probably a really good drug for someone who has their wisdom teeth pulled out because it needs to be activated. It's one of the most likely drugs to cause nausea. It's not cleared very well in renal failure, and it's just yucky. So I think codeine probably doesn't have a role for our cancer patients. Meperidine, people will go to the far ends of Alabama to find some ER that will give them that Demelol, but I tell them every time that they won't be getting it from me because really I don't even know how we still get this drug. It's really not a safe drug. We pulled propoxyphene off the market a few years ago, and meperidine is probably in that class where it's just one of these drugs that it does have some benefit, but it's just not a very safe drug. The risk of seizures and neurotoxicities is high. It's variably effective. It has side effects. If we're going to use a pure opioid, just use a pure opioid, and there's really not an indication. If someone has Rigers because of IVIG or Rigers because of rituximab, morphine works just as well. It's a class effect. It's an opioid effect. We don't have to give meperidine for that. And I tell my gastroenterologists that, but some of them still think that it has to be used for an EGD, but I conscientiously objected when I had mine to have anything but fentanyl during mine because I didn't want meperidine. And the last is tramadol, and I just want to mention tramadol because I think tramadol lulls us into this sense of, well, it's not really an opioid, so it has to be better. Ooh, this person's a drug addict, so we're going to use tramadol with them. Or, ooh, this person's old and I don't want to make them sick, so I'm going to use tramadol. All kind of false, fallacious beliefs. It has a tricky mechanism. It's mu, but it's also SNRI. So it has drug-drug interactions. It can increase the risk of serotonin syndrome and can lower seizure threshold. It can be one of those things where people are on it for a long time and then they get stopped and switch to an opioid, and then they get a nasty tramadol discontinuation syndrome, so we have to taper them off of tramadol. And until you've admitted somebody who comes in with hypoglycemia from it, and that's really refractory hypoglycemia, getting D10 infusions, you realize that this drug really isn't that safe. And I could probably use 2.5 milligrams of oral oxycodone for my elderly patient, even with dementia, and they're going to do just fine with that. The problem is that we write prescriptions for oxycodone, 5 milligram tablets, 1 to 2 every 4 to 6 hours. And that's a recipe for, I don't know what to do. It said 1 or 2, so I thought 2 would be better. Or it said 4, but it hurt at 3, so I took 2 at 3. That's the problem. Sometimes just being we're going to try a half a tablet. And if that half a tablet doesn't work, let's try a whole tablet. But let me know before we do that. That's where I think we get into trouble that we could avoid. If we just use lower doses of opioids, we know what we're getting with an opioid. We're getting predictable side effects, predictable benefits, and predictable toxicity. With tramadol, we just aren't getting that. Okay. So now getting back to cancer-specific things. I think whenever we have pain that's in the setting of a tumor, we have to think about, is antineoplastic therapy going to help with this pain? And I think a lot of times it does. And we, as non-oncologists in the internal medicine type world or the geriatric world, forget about the wonderful things that can be done with antineoplastics or hormonal agents or radiotherapy that all can have pretty dramatic effect on bony metastasis, on tumors pushing on nerves, recognizing that we have patients that might have impending pathologic fractures and that orthopedic stabilization might be a good thing to move towards early because a pin now will prevent a total hip later. These are things that we need to really be aware of, and that's why I think when it comes down to this multidisciplinary approach, how can we all help each other? And this is where I need to talk to my radiation doc and say, I think this person needs some radiation, but their prognosis is really not that great. I think 10 fractions is not going to be feasible. Can we think outside the box? Because of course we could write for 10 fractions to 30 gray of a solid tumor, but if someone's really not doing that well and they want to get home to Wade, Northeast Alabama, sometimes that's what I want to do. I want to get them the amount of radiation therapy that's going to make them feel better, recognizing that their prognosis is limited. And sometimes, again, it's a matter of recognizing that prognosis is limited. That's a hard discussion to have. Sometimes we don't want it. We want to put our blinders on about that. But sometimes that helps the family to make very important decisions like, maybe we shouldn't do that radiation therapy because it makes us stay in the Mobile Bay area and we just want to get to South Central Mississippi, and that's where we need to be. So lots of different thoughts about that. When we look back to our NCCN guidelines, they agree that if goals are not achieved in very, very tiny print, that interventional consults can be appropriate. So basically that they recommend either nerve blocks or other types of neurodestructive processes, which I want to spend a little bit of time on. And again, they recommend a whole other type of options, particularly for neurodestructive, but I want to bring this to a little bit more of a readable font. So when we think about procedural control for cancer-associated pain, we talked about radiation, chemo, and surgery. One approach would be a neuroaxial approach. So if the person has severe pelvic pain, has something that's causing some neural compression, giving opioids via an epidural, via intrathecal approach can be very, very effective. Every hospital is different on this. When I was in Virginia, it was very, very common that someone, if they had pelvic pain or severe lower extremity pain, that you'd put an epidural in them and you'd treat their pain just like they were someone who was in labor, except maybe you didn't use as much of the anesthetic because they needed to feel their legs to walk and not necessarily needed their legs to be, more numb. So sometimes it is just kind of seeing that approach. Can we use the drug directly, less opioid with a little bit of anesthetic, and that could be something that could be highly effective. And then if that does work and the person has a prognosis, then we might put an intrathecal drug delivery system in them. And I had several patients who had intrathecal drug delivery systems for recurrent cervical cancer, for chronic pelvic pain that was not something that was benefited by a block by itself. Patients who had breast cancer that was metastatic and had a lot of spine disease or generalized pain, where you could give them a ton of oral opioids, but 300 milligrams of oral morphine is 100 milligrams of IV morphine, is 10 milligrams of epidural morphine, is 1 milligram of intrathecal morphine. So if we're worried about the amount of side effects, we're able to reduce the amount of morphine by 300-fold by putting it right into the intrathecal space. So that's why sometimes we need to ask our pain physicians, is this something that would be helpful? Or ask our pain physicians or our interventional radiologists, is this something that might benefit from an ablation? So whether the tumor is ablated by alcohol, radiofrequency, or cryo really depends on where the tumor is located and what the interventional's preference is. But when we talk about blocks and ablations, we'll talk about those on the second page. When we think about the celiac plexus, which generally is involved with our pancreatic type tumors, that's where a splanchnic or a celiac plexus block, that's going to help that upper abdominal pain. Tends not to help a lot of disease in the liver because the liver's capsule is innervated differently than the splanchnic area is innervated, so we have to remember that. But I think the superior hypogastric block for pelvic pain and sometimes even a deeper rectal pain is something that can be very, very helpful. I've certainly had patients with gynecologic malignancies that this has been recommended for. And again, it's really trying to allow for the nerves to be numbed up, depending on what their prognosis is, maybe even burned or treated with alcohol. And if we're going to ablate the nerves, generally that's going to be for someone who is at an end stage process where we're looking at a survival of 6 months or less, because we don't want those nerves to be ablated and then come back aberrantly and cause a worsening pelvic pain syndrome a year or two down the road if they're going to be long-term survivors. So this really is something that we can do a block with anesthetics and with steroids, but if we're going to do something that's truly neurolytic, where we're going to destroy the nerves, we want to make sure that they're approaching the end of their life. Sacrococcygeal or ganglion impar blocks, very superficial things that are on, within the anal canal. Sometimes within the perineum, you can get some more posterior perineum. You could get some really good benefit, and this is a very easy block. Most folks will say this is, of those, one of the easiest ones to do. And then certainly they talk about sympathetic blocks for leg and arm pain, thoracic malignancies, so we're thinking more in the breast cancer population, where we might have metastatic disease or primary breast disease, tumor burden there. So the last 5 minutes that I want to take to keep us roughly on time is talk about some of the safe prescribing things, because we talked about procedures, we talked about adjuvants, we talked about how to manage the pharmacologics the best we can, but how do we manage our license and our practice the best we can? And really, I think the CDC's come up with a good approach where we're just looking at the concept of universal precautions. So this is the slide. These next two are the ones that we were looking for. They're the blank ones at the end. So basically, when we're thinking about what they call universal precautions, just like we would always wash our hands and put our gloves on, and we would always, make sure that we're initialing the right side of the body to do surgery on, that if we have patients that aren't at an end stage process, if they're on greater than 50 milligrams of oral morphine equivalents daily, the whole concept of prescribing naloxone is something that's gained a lot of traction. And I think that this is something that, again, sometimes in my world, I don't necessarily think about prescribing naloxone for folks because I might be putting them on hospice or I might be putting them, with a more terminal condition. But I can tell you, when I have a young patient who's only on her second line of treatment for advanced receptor-positive breast cancer with extensive osseous disease, I know that there might be 4, 5, 6, 7, 8 lines of chemotherapy that our oncologists are going to think of for that person, and appropriately so. So this person might have a prognosis, and if I think there's going to be a problem where they might misuse them, or where there are other people in the house who might misuse them, I will send naloxone home with them. What I have asked, well, at the VA, anybody for chronic pain will get naloxone sent home and a letter sent about it. What I've asked is that they not do that for our palliative care patients. Kind of let us make the clinical determination, because again, most palliative care patients, we're looking at a different prognosis and a different set of goals. The second one we really don't have a lot of choice with, and this is the PDMP. And if you don't have a PDMP login as a clinician who prescribes opioids, you're going to need it. And you're going to need lots of proxies, up to the maximum of 3, that can look at folks and say, okay, if I'm writing for even perioperative opioids for someone to go out, for a prescription, the VA's guidelines are longer than a 3-day prescription. If you write for any opioid longer than a 3-day, you have to justify that you looked to make sure that they're not getting the drugs from somewhere else. And the cross-state databases are fairly good. I imagine that the Mississippi and Florida become much more important in this part of the world, where we need to look at other ones as well, because people can go across state lines. But really knowing, are they getting multiple dangerous substances? Are they getting opioids from other sources? Are they quote-unquote doctor shopping? But there's a lot of stuff that pops up there that is surprising. So pregabalin, testosterone replacements, methylphenidate. These are all things that we kind of forget are controlled substances. They all pop up on there. So you learn a lot of interesting things about your patients by looking at that and making sure it's appropriate. Urine testing. I think this is something that having a baseline urine is helpful. This is where we could give a whole other hour talk about what to do with positive urines or inappropriate negative urines, and it's a tricky situation. It really comes down to, I look at a urine is there something in that urine that's leading me to believe that the meds aren't being used as appropriate? If someone's on 5 milligrams of oral oxycodone and their urine screen is negative for oxycodone, I might not put a whole lot of trust in that. That's a little bit of medication. If they tell me they're taking it every day and they need more and there's no opioid in their urine, that's a little worrisome to me. And might lead me to believe, are you taking it? Are you diverting it? Is someone selling it, stealing it from you, swapping it out? All things that are true, I just unfortunately see them more frequently than not. But also for me, it's sometimes more about what's in there, and someone's like, this urine, one of my colleagues, this urine, it's just, I know she said she's taking that fentanyl, and it's not in her urine, and I'm gonna stop writing her fentanyl. And I said, the bigger problem is that there's cocaine in her urine. So let's talk about cocaine and how cocaine is not something we'd like to see. And I think back to my favorite patient of all time during fellowship, who was a cervical cancer survivor, and I love her to pieces, and she would talk me up, that Dr. Swetz looks so good. You look mighty fine today, Dr. Swetz. And I said, there's cocaine in your urine. And she's like, I don't know how it got there, doctor. And then I said, I know. So you have a pump, we put a pump in, you get a little bit of oral meds to help. And then, there's cocaine in there again. Dr. Swetz, you can't stop, I have cancer. And it's like, yes, you will not get written opioids from me anymore. I'm sorry. Like, you have a pump, we put it in, it's a surgical procedure, we'll manage it, but I will never write another opioid for you again because I can't trust that you're not diverting them, I can't trust that you're not selling them. So, does that make me feel good? Absolutely not. I hate it. I absolutely hate it. But when it comes down to it, it's my license, it's my safe practice, it's my responsibility to the patient to not enable a behavior that can be more destructive. And for me, cocaine puts someone not in the low risk. Where I see people get all fancy, and worried is, there's cannabis in there. Okay. I'm not talking about morality of anything here in the state of Alabama. I work in the state of Alabama. I work for the federal government, both of where cannabis is not legal. Do I know that I have patients that are in other states that use cannabis and have reasonable relief of their symptoms from it? Sure. Do I think that they're getting rid of their pain medicine to trade for cannabis? Probably not. Probably not. It's not a good deal, from what I understand. It's kind of like, giving away like your higher Pokemon cards for a lower Pokemon card. So it really comes down to, look at it and say, is the stuff that should be there? Is there stuff that shouldn't be there? And does this make me believe that the person is either making themselves or others at risk? That's how I use it. Every person who comes in and has cannabis in their, I'm not going to sit there and say, I'll never write for pain medicine for you again. It's not my role. Yet, I can imagine that primary care doctors who are scrutiny for number one are looking for every reason in the world not to write any opioids for their patients because it's just too much of a hassle. So that's where I think we need to be a little careful as cancer specialists about we're in a different space. We have patients with different prognosis. We definitely do not want to be taken advantage of, but we have to have some semblance of understanding. And the last one I think we need to be careful with is, again, in the palliative care world, everybody has opioids and benzodiazepines. In the real world, for patients who are chronic, it's not a good idea. So it's it does become that, if I could just have alprazolam for my anxiety, I would be better with the oxycodone as well. That's really dangerous to have both of those. So I need to know what's worse. Is your pain worse or your anxiety worse? People will prioritize it for you very quickly. particularly when you could say, I could manage your anxiety using non-benzodiazepine agents such as SNRIs, SSRIs, psychotherapy, and lots of other things. Sometimes their anxiety comes from, worrying about, is their cancer back? Is their pain going to be controlled? So that's where this team approach is so important, because we all bring something important to the table. And then the clinical reminders, I just pulled up some of the bullet points here that I think are just helpful, if you're gonna write for opioids, for something that's a chronic pain. Because again, I have my clinic starting in women's cancer clinic in May. One of my colleagues is doing it now, but I'm gonna be taking it over in May. And I've taken care of lots of folks that are cancer survivors that struggle with very severe pain, strictures, just bad problems related to radiation, enteritis that's chronic, and lots of different things. So the first question we have to ask is, did we try other things first? Did we really say what the risks, benefits, and alternatives to the opioids are? And what are the goals of the opioids? If the goal of the opioid is make my pelvis pain go away, I don't think I'm going to meet that goal. So let's not set ourselves up for failure in the beginning. Our pain management may help you to be more functional. It may help you to achieve things that you're not able to do right now because you're limited by pain. But to take your pain away is probably not going to happen. So if that is your goal, and I don't address that as your prescriber, then we're setting ourselves up for a situation where this is not going to go well. So what are the reasonable expectations? They remind us to start using immediate release and start low and go slow. It's amazing. So this is something that I think people look, oh, you're a big guy, you're a pain doctor, etc. You have kidney stones, and I can tell you, when I've had my kidney stones, a half of a Norco does just fine. Well, they give you the big because you're big, so you get 10s or 7.5s, and you don't want to come back. But I've never even tried a whole one. I just said, I'm going to start with a half. And I broke it in half, and I was like, oh, my pain's gone. Okay, I'm going to go. I could function again. I don't think a lot of people think about that. I think a lot of people think about we're just going to start because they're in pain. We want to get them out of it. The lowest possible dose sometimes will be surprising. People will say, oh, I have good function with that. They don't need to have 360 tablets often written for, although when the VA pharmacy sees that someone has a prescription for 360 and it's mine, they're usually not surprised at this point because people get a pound of methadone here or there because sometimes they do need higher doses. But the wisdom tooth or the uncomplicated THBSO probably doesn't need 360. If someone has acute pain that's going to get better, they shouldn't be started on long actings. You need to evaluate risks and harms. You need to follow up. You need to check the PDMP, and drug testing as appropriate. The benzos are definitely a problem, particularly for our elderly folks. And then we really do need to recognize when we're seeing abnormal patterns, is this an opioid use disorder? Is this opioid misuse? Is this tolerance? Is this addiction? Is this pseudo-addiction? And these are all terms, again, that we could talk about for a long time. But again, is the person using the medicine correctly to treat pain and something's going wrong, or do they really have an opioid use disorder where they will lie, cheat, and steal just to get high? And that's how I tell patients. Most of my patients don't come in and lie, cheat, and steal to get high. Most of my patients need more medicine because they're tolerant. They used a certain dose, their disease is getting worse, they need more to make it work. So, summary is in your slides, and to keep us relatively and allow us to answer any questions or do your post-test, I just wanted to stop here. Any immediate thoughts or questions? Use much methadone? Use a lot of methadone. So this is the way I describe methadone. For me, when I was an internist before I did my fellowship, I would let others tell me how to use methadone. So methadone to me is kind of like my father's weed whacker, right? He said, you don't use it until I show you how to use it, because you don't know how to use it and you could hurt somebody. And I think that's the same thing. If you're comfortable with it, if you know how it works, it has great properties. I think particularly for chronic pain, it's awesome. I think for neoplastic pain, it's awesome. as long as the person's going to be reliable and not self-titrate, I think it's super effective. It's dirt cheap. Insurance loves it. But you can't have this person who says, yeah, I take, tell me how you're using. Well, I'll take 5 of those oxys that you give me and I don't feel better. Well, methadone, you take 5 of them, you might die. Like, die. You understand that. I'm very frank with patients about that. Like, you do not up-titrate without me. You don't get prescriptions from elsewhere. But it's super effective. And I think it is one of those things where it's not a 101 level prescriber thing. I think that folks should at least have a 201 level understanding of the drug because it's complex. But it's super effective and we use it all the time. Okay. Well, thank you so much. I appreciate y'all being here.